DEXA, as I mentioned, is something that I do in most of my patients who are elderly, whether they have come with an osteoporotic vertebral compression fracture or otherwise with bone and joint pains. For most orthopedic surgeons, a T-score of minus 2.5 and below warrants medical management. Minus 2 and below T-score with diabetes and certain other things like glucocorticoid, etc., would warrant medical management. Hence, we should look at these patients with a high index of suspicion who need medical management besides surgical intervention. What then is the medical management available? How much should we practice? How much should we involve our geriatricians, our endocrinologists, our rheumatologists into the picture? Something each one of us learns with experience. Give them regular calcium and vitamin D3, and we start that even in the premenopausal age group. In fact, women after the age of 20-25 should start taking calcium regularly. Postmenopausal, HRT and SERMs are still being used. Bisphosphonates, still the baseline of treatment. Oral therapeutic, 70 milligrams alendronate. Maintenance, 35 milligrams weekly, bisphosphonate. Teriparatide, the biggest kid on the block, as we called him 10 years back, has been there now for more than a decade. The only anabolic available, 20 micrograms subcut daily for 2 years. And the latest kid in our monoclonal antibody, denosumab, a 6-monthly 60 milligram subcut injection. Advantage, can be used in the renal challenged, can be used up to 10 years without significant side effects. Each one of these to be used as per indication, as per the age of the patient, and in a cascading form, as you need to move from one to the other to the third and hope that a fourth will come out sooner or later. All these patients will need medical management and would need splintage for pain relief for a short duration of time. Minimum rest in bed. I do not recommend rest in bed. In fact, I tell them to wear a brace or a belt which gives them both physical and mental support and get them out and ambulatory, provided they are neurologically preserved. Suitable medication, along with a physician, geriatrician, or endocrinologist, and pain relief. We need to give them pain relief. They may be in the form of patches. Some of us even use calcitonin nasal spray more for pain relief than as a true anti-osteoporotic. Some of us may need to give pain blocks if they are in agony. All these as far as the non-invasive basket is concerned. However, some of them need intervention. That is where we as orthopedic spine surgeons come into the picture. We need to augment a few of these subacute painful conditions. Why do I say subacute? I do not recommend using cement augmentation on day 1 or 2 post-injury. There's a very high incidence of cement leakage, and between you and me, 70 to 80% of these patients would otherwise settle down without invasion. Give them 6 weeks of pain relief, splintage, modified lifestyle, and they don't need cement augmentation. However, in that 10 to 20% who don't settle down, we may consider in subacute painful situations, non-neurological, where there's no cord compression, some sort of cement augmentation, vertebroplasty or kyphoplasty. We've gone through this entire jargon of vertebroplasty, then kyphoplasty, then back to vertebroplasty. The truth is, cement needs to be put in and reduce the instability. The aim is not really correcting that kyphosis. In fact, accepting that kyphosis and making it painless is the aim of the procedure.